I am very pleased to introduce today's speaker, Dr. Colleen Buggs-Saxton, who is an associate professor in the Department of Pediatrics with a secondary appointment in the Department of Physiology. Her specialty, she is a specialist in pediatric endocrinology. She is a native Detroiter, graduating from Tech High School, and from there received her undergraduate degree from the University of Pennsylvania and her MD and PhDs from Harvard University. She completed her residency training at Children's Memorial Hospital in Chicago, and then her pediatric endocrinology fellowship at University of Chicago Children's Hospital. In 2009, we were very fortunate to have her join our faculty at Wayne State University, where she has worked very hard, both in general endocrinology and in specifically in the area of pediatric diabetes. She has several research projects as well as clinical trials. She has mentored and advised several students, both on the undergraduate level, medical school, and residency and adult endocrinology fellows. So please, without further ado, let us welcome Dr. Colleen Buggs-Saxton.
Thank you, Lynn, for that introduction. Let me share. Can you see my screen?
Yes.
Yes, but it's not in presentation mode at the moment. Yeah. There it goes.
Presentation. Okay. Can you just see the presentation mode, this full slide?
No, we're in the
presentation mode. That's okay. All right, I'll just go this way. All right, so Thank you for that introduction, Dr. Smitherman. And it's a pleasure to present in the pediatric grand rounds for Wayne Pediatrics, and welcome our colleagues at St. John's Hospital as well. The topic I chose was childhood obesity, and hopefully we'll walk away from this with more insights into what's in the future for these children. The objectives this morning are as follows. I will review the definition of pediatric obesity and the obesity epidemic. I'll discuss the risk of obesity-associated comorbidities in pediatrics and review treatment guidelines and practical intervention for management of pediatric obesity. This is important because we don't have enough endocrinologists available, and we're seeing more and more of these children in general pediatric clinics. Lastly, I will discuss, in addition to the role of bariatric surgery in the management of severe obesity, I'll also give an overview about pharmacological treatment options for children who progress with obesity. Let's start with defining obesity. Overweight and obesity indicate that there is an excess of the amount of fat that increases the risk of health problems. And the terms are more accurately defined by calculating body mass index, which we are familiar with. So it's the weight in kilograms divided by the height in meters squared. The definition for overweight in adult, I'll start with that, is a BMI that's equal to or above 25, but below 30. And obesity in adult is a BMI that's equal to or greater than 30. BMI correlates with body fat, but is not a direct measure of body fat. It's also the clinical standard measure of overweight and obesity in children that are 2 and older. It's still an estimate of adiposity in children, it's not perfect. It can overestimate adiposity in a child who is short or has high muscle mass, and underestimate adiposity in children with lower muscle mass. It's also important to remember that unlike adults, absolute BMI changes as a child grows. And this can impact how you manage overweight and obese children. But it's also important to recognize that we use the BMI percentile to assess overweight and obesity in children using the CDC growth charts from 2000. And there are sex-specific and age-specific BMI growth charts. First, let me review the weight categories that we will use when we define what's normal weight, what's overweight and obese. So normal weight is a healthy weight that's equal to BMI percentile that's equal to the 5th up to the 85th percentile. Overweight starts at the 85th percentile. So a child with a BMI percentile in the 85th to less than the 95th percentile is overweight. If the BMI percentile is equal to or above the 95th percentile, that's obese. And then everything else is considered severe obesity, and we'll talk more about this. The definition is 120% of the 95th percentile, or what's considered the 98th percentile, or if it's above 35, a BMI of 35, so that's severe obesity. And I'll show you the BMI growth charts, and you can see on the left-hand side is the BMI curve for boys and the right side for girls. And I just highlighted where the 85th percentile is. So any points below that highlighted line in green or yellow, if it's above the 5th percentile, is a healthy weight child. And so we're going to be focusing on the BMI points that are above these colored lines. And the prevalence of overweight, so that's a child with a BMI percentile equal to or above the 85th percentile, but below the 95th. And in preschoolers is about 12%, school-age children 15%, and your adolescents 19.4%. So that's just for overweight. Now we're going to talk a little bit more about the percentiles that are above the 95th. So there's classification that allows more separation into severe obesity in pediatrics. So class 1 is a BMI of equal to 30, but less than 35. Class 2 is a BMI equal to 35, but less than 40, or 120% of the 95th percentile. So that's like the 98th percentile, but less than 140%. And then class 3 are children with a BMI that's equal to or greater than 40, or 140% of the 95th percentile. So these are BMI curves for severe obesity. So remember, we're really focusing on the pink color part of the curve, and you can see overweight is 85th to 95th percentile. Class 1 obesity is going to be a BMI of 30 to 35, class 2, 35 to 40, and class 3 above 40. So what's important to remember is once you hit the BMI cutoff, it puts you in that category. So for example, for this individual who's is at a BMI of 40, before they're above the 140th percent of the 95th percentile, we'll classify them in the higher class category. So this child would be considered to have severe obesity. class 3. And the same applies for females. So what's the prevalence of severe obesity? So in preschooler, about 11% class 1, and you can see as the age increases, the teenagers have a higher percent in the higher classes, so class 2 and 3, and females 10% and males 13.2, versus in the preschoolers, only 2% of them are in that class. So we've learned and we've heard a lot about obesity, the crisis, for many decades now. And so let's look a little bit more at the trends and what has changed over time. So this was the first evidence of an alarming increase in obesity that was first noted in the late 90s, where they showed that when you looked at two groups of pediatric patients, so ages 6 to 11 in the yellow and 12 to 19 in the green, back in the mid 70s, early 80s, the rate of prevalence of obesity was fairly low, about 5%. It doubled by the time you got to the late 1990s and the younger age group, and tripled in the older age group. So this trend continued over the last 4 decades, and you can see a steady increase across all age groups, with some plateauing after the 2000s. However, this graph does not clearly show that there's that increase in the severe obesity group among pediatric patients. There was a period among the younger age preschoolers where there was a decrease in the prevalence of obesity, but you can see there's an upward trend after 2008, 2012. So with regards to prevalence, when you put it together for overweight or obese individual, about 1/3 of children and adolescents in this country fall into that category. So about more than 20% of preschoolers and more than 30% of school-age children. And I just want to note that during the COVID-19 pandemic, it was the 6 to 11-year-olds where we saw the biggest increase in obesity and overweight, from 19 to 26% during that first year. The teenagers still have the highest prevalence of being overweight or obese. Prevalence varies by race, ethnicity, and socioeconomic factors. We see higher prevalence in African Americans, American Indian, Latinos, and non-Hispanic compared to non-Hispanic whites. It's more common to see obesity among children from low-income families. There are both genetic and heritable factors. If one parent is obese, the risk of obesity in a child increases by 2 to 3-fold. If both parents are obese, that risk escalates up to 15-fold. So why are we concerned about obesity in childhood? Well, there's longitudinal studies that have shown that obesity in early childhood contributes to obesity in adolescents and also in adulthood. So what's the evidence? So the presence of obesity or being overweight in preschool increases the risk of obesity persisting later in childhood. So if you have an overweight kindergarten, that child is 4 times more likely to become obese in the 8th grade, so when they're about 14, compared to a classmate who is not overweight. Among children who are obese in kindergarten, so we've gone from overweight to obese, they have almost a 50% likelihood of remaining obese in the 8th grade. And then children who are severely obese in kindergarten, 70% of them remained obese in the 8th grade. It's also depicted in this graph where you can see that when you're overweight, this is BMI percentile at entry into kindergarten compared to obesity in the 8th grade. So when you are overweight, you can see that you have an increased risk of being obese in the 8th grade. And if you're obese, it approaches 50%. And severe obesity, it approaches 70%. In addition, being obese early in childhood contributes to the persistence of obesity into adulthood. So there was a longitudinal study of obese children at age 5, and they were followed through adolescence at 15 and 17 years of age, and then into adulthood at 50 years old. And what they found was that the adults who were obese at age 5, their BMI scores were 6.5 units higher compared to adults that had a normal weight when they were younger. And the probability of being obese as an adult, you could predict it about 67% based on obesity at age 5, but it was a higher probability of 86% if you were still obese during adolescence. Other studies have examined does gender or sex impacts progression of obesity into adulthood. There are variable results. Initially, it was thought that there was a higher risk for obese females, but additional studies have found that both adolescent males and female who are obese will likely persist with obesity into adulthood. So, what is the impact of obesity on morbidity and mortality? So, in the US, obesity is a leading cause of preventable deaths at an estimate of 280,000 deaths annually, and it's expensive. In 2008, obesity and related health costs was more than 150 billion, and in 2016, it's almost more than triple that, to close to 500 billion. And it's more prevalent than smoking, and it's highly associated with multiple chronic conditions. Obesity is a complex chronic disease. In healthcare, or even in society, we often view an individual with obesity as something that they could prevent, and is due to lack of discipline or poor personal choices. Just stop drinking sugary beverages and decrease your portion sizes. Turn off the television, exercise. We now understand, because it is a chronic disease, there's a complexity to it. So there's genetic, physiological factors that are impacted by psychosocial, socioeconomic, environmental factors. So obesity, from a genetic perspective, is a polygenic disorder with about 30 to 50% of variation in adiposity caused by heritable factors. We do recognize when there's early onset obesity, we should really try to screen for monogenic causes of obesity in children, like leptin deficiency or melanocortin-4 receptor defects or mutations. Syndromes can be associated with obesity, so especially a child with dysmorphic features, but this only accounts for less than 1% of childhood obesity, and the most common syndrome associated with obesity is Prader-Willi syndrome. What about endocrine causes? Once again, very rare. About 1% of childhood obesity is due to endocrine causes Cushing's, hypothyroidism, growth hormone deficiency. And the key is that there's poor linear growth despite the weight gain. What are some psychosocial factors that contribute to the complexity of obesity? We know that emotional distress contributes to excess weight gain. For example, a child may overeat to avoid negative feelings. So this is like a maladaptive strategy. Parental feeding style, stress, and depression can all impact eating behaviors in children. And also adverse childhood experiences have been associated with obesity in children. There are socioeconomic factors regarding access to healthy food options and other factors that lead to decrease in physical activity by increased involvement in sedentary activities, watching television, computers, online school, using tablets and smartphones. And there could also be changes in your community and your school environment, like not having an option for a physical ed class. Environmental factors, risk of a child becoming obese is also impacted by the neighborhood. Is it safe for that child to exercise or to walk outside? What are some of the healthy food options or choices in the neighborhood? Are they affordable for that child, for that family? So all of these factors overlap and can influence the development and progression of obesity throughout the life of the child. We also recognize that there are short and long-term consequences to childhood obesity. I've listed several of them here, and we'll just discuss a few. But I think about this, and I equate it to when I talk to patients about going on a vacation and putting a lot of stuff in your luggage. So this is what happens when you have an obese child. There are many other parts of the body that's affected by this condition. So focusing on childhood obesity and risk factors for type 2 diabetes, the major risk factor is being overweight or obese. So a BMI that's equal to or greater than the 85th percentile for age or sex, plus one of the following minor risk factor is a maternal history of type 2 diabetes or gestational diabetes during the child's gestation, a family history of type 2 in a first or second degree relative, race or ethnicity, or signs of or conditions associated with insulin resistance, acanthosis nigricans, hypertension, dyslipidemia, polycystic ovary syndrome, small for gestational birth weight. So these are the children who have an increased risk of developing type 2 diabetes. How do we diagnose it? Fasting plasma glucose is elevated, greater to or equal to 126, elevated hemoglobin A1C with other symptoms of diabetes, increased thirst, urination with some other measurement of hyperglycemia as well, random glucose above 200. We very rarely perform oral glucose tolerance tests, but if it is performed, a 2-hour plasma glucose level that's equal to or greater than 200 are all diagnostic for type 2 diabetes. There are complications associated with type 2 diabetes, so macrovascular disease, there's not just diabetes, but you have an increased risk of coronary artery disease, cerebral vascular disease that can cause ischemic stroke, peripheral vascular disease, as well as microvascular disease that can cause blindness, renal failure, and limb amputation with neuropathy. And so these children with type 2 diabetes and obese, they have to be screened for these conditions annually because their risk of complications is much higher than what we see in type 1 diabetes. What are some of the cardiovascular consequences of childhood obesity? Elevated blood pressure contributing to the development of hypertension. You can see evidence of endothelial dysfunction, increased carotid artery stiffness, especially in the intima media thickness. So, and some children who have an echocardiogram may have findings showing increased left ventricular mass or hypertrophy or increased left ventricular diameter. So structural changes to the left ventricle. And then metabolic syndrome. So you have the obesity with hypertension, insulin resistance, and dyslipidemia. So we understand that it's a problem and we have to have a strategy for identifying the children who are at risk. So those who are at risk for becoming obese are children who are overweight. So BMI that is equal to or greater than the 85th percentile for age and sex. So you want to get a detailed medical history, birth history, with some details about the mother's history, medical history during the pregnancy, and also the developmental history of the child. This is important, especially for early onset obesity, if you're thinking about syndromic causes like Prader-Willi, where children can have a history of hypotonia, decreased problems with feeding in early infancy. You also want to get details about the history and their eating habits, not just that are you drinking sugary beverages, but the frequency of eating, the content of the meals and the snacks. Where are they located? Does the family eat together? How often do they go out? We used to focus on going out for fast foods, but now we have to ask about the delivery of food. There are so many times parents are telling me, oh, they order from DoorDash. So, you know, we have to be mindful of getting that information. Regarding the intake of beverages, I'm still very surprised when parents tell me that the child drinks 100% juice, thinking that that's healthy for the child. So really getting a thorough history about all of the sugary beverages that they are consuming. And as best as you can, the amount. A physical activity assessment, unstructured play time versus organized sports, school recess, physical education classes, screen time, not just how much are they watching television, video game use, mobile phone use, computers and tablets. And don't forget sleep habits, duration and quality. This is also important. Medications. We have a lot of children with behavioral health issues, and they are taking medications that can contribute to weight gain. I just saw a patient yesterday who's gained like 24 pounds since November after starting, you know, a medication to help with management of depression. So just counseling that patient about the choices of foods that she selects when she's hungry is important. Also in the history, a family history of obesity and associated conditions, the parent's weight status. And this will allow you to have some sensitivity to talking to the family about this issue, because oftentimes, you know, the parents are obese. And so your approach to talking to their obese child is also directed at the parent. So, you know, your sensitivity, you know, to this issue is very important because you need that parent's engagement to help the child. physical examination, reviewing the growth chart, BMI percentile. I think it's very important that we show the parents and caregiver the growth chart. I often do that. I'll print it out and say, did you know this is your child's growth chart? Do you know what this means? And really engaging them into the first signs, that, there are concerns. And this also gives you an opportunity to assess abnormal changes in linear growth. Most children with exogenous obesity are tall. And most obese children with short stature may have an organic cause to obesity, genetic or endocrine. So that would be an indication for a referral. Review vital signs. It's important to make sure that the appropriate blood pressure cuff is used, especially when measuring blood pressure, because it may be falsely elevated because the appropriate cuff size was not used. So repeating that or paying attention to that detail, and also having the different cuff sizes in your office so that it will be available to assess these patients. And also assessing for dysmorphic features. Once again, that would be an indication for syndromic obesity. There's not a lot of consensus about laboratory tests that should be used, but there are some recommendations based on the likelihood of finding an abnormal result. So if you have an overweight child or an obese child without any risk factors, at least start by doing a fasting lipid profile. Most children will have one or two abnormalities, either in HDL cholesterol or triglyceride level. Now, moving to the next stage, additional labs we recommended if you have an overweight child who is 10 and older and also has one of the following risk factors. So an abnormal lipid profile, elevated blood pressure, if the child is using tobacco, or if there's a family history of obesity-related disease, such as diabetes or fatty liver disease. In addition to the lipid profile, it's recommended that you assess glucose levels either by a random blood glucose or fasting blood glucose or hemoglobin A1C, and also measure ALT and AST. If you have an obese child without risk factor who is above 10, you would also get the same set of labs. How would you manage the results? If the lipid profile is normal, it's recommended that you repeat it every 2 years. If they're slightly abnormal, repeat it in 1 year. And if abnormal, you can repeat it at least by 3 months and refer for treatment. If they're above 10, or if there's another reason to refer with family history. Order endocrine and genetic testing if indicated. And don't forget to evaluate for obstructive sleep apnea. I typically refer to pulmonary because I want their input in interpreting the polysomnogram and management of it. So it's recommended, the AAP is recommending a staged approach to managing pediatric obesity. So you first start by assessing obesity risk during a well child care visit. So you measure and plot the BMI, evaluate diet habits and behavior, evaluate physical activity and sleep duration and quality. And if the BMI is in a healthy range, you may want to talk about obesity prevention, really focusing on healthy dietary and physical activity habits, and making sure that you reassess these issues at your subsequent well-child visit. Now, if the BMI is equal to or above the 85th percentile or rising sharply, then you would want to do what's called prevention plus, initial weight management counseling. So you're going to spend more time counseling and really identify specific behavioral goals to support weight management and assess for disorder eating patterns. And I'll go over the stages in more detail in this table. So we have stage 1, which is prevention plus. And this can be done in a primary care office setting. You want to stress the importance of eating more fruits and vegetables per day, and give ideas about how they can make that happen. So I often will encourage parents to, serve the fruit and vegetable as a side dish, make sure you have it as part of your dinner meal or part of the lunch, and making sure that the fruit and vegetables are easily accessible and visible. So, put fruit out on the table so that it's in front of the high-fat snacks that are in the cabinets. Really minimizing and eliminating consumption of sugar-containing beverages. So, this is tricky, especially in young children who go to school and they like their chocolate milk and strawberry milk. So I want them to enjoy it, but not have it every day. So I'll give them like 3 days a week, and I let the child decide what 3 days they're going to have chocolate milk. So if it's Monday through Wednesday, then that means Thursday and Friday they can't have it. The plan is over time, you can flip it and maybe decrease it to 2 days a week. But it's a matter of balancing kind of expectations and just working with the child to decrease over time their consumption of sugary beverages. When it comes to juice, I really promote eating juice. So, and that's something that young children can understand. So I said, if you want apple juice, eat an apple. If you want orange juice, eat an orange. So I really try to come up with creative ways to decrease the sugary beverages. So at this stage, we'll monitor for 3 to 6 months. And what are we monitoring? So weight loss goal is determined by the child's age and severity of obesity and related comorbidities. So a child with mild obesity, weight maintenance may be the goal because BMI will decrease as that young child grows. However, if you have an older child or a younger child with severe obesity, then you may want to focus on weight loss. So what is recommended for ages 2 to 11? About 1 pound per month. For adolescents with comorbidities, 1 to 2 pounds per month, and up to 2 pounds a week may be safe for these adolescents. Stage 2 is where you involve a dietitian to provide more guidelines for increasing structured meals and snacks with attention to energy density of foods, and we'll talk about that. Stage 3 can be implemented in a primary care office, but may be more appropriate if you have a multidisciplinary team or outside facilities for structured physical activity like Fit Kids 360. And tertiary care is a more specialized pediatric weight management center where you have options to medications and perhaps even bariatric surgery. So behavior strategies is important with managing pediatric obesity, and the goals are decreasing caloric intake, decreasing sedentary time, increasing physical activity. So family-based behavioral approaches work best, include parents and caregivers. Motivational interviewing techniques are important, just assessing readiness, listening, and really trying to help the patient overcome some of those barriers to making changes. What are some of those barriers? Could it be financial? Could it be cultural? Helping them to monitor their behavior and their changes. Setting SMART goals is very important. I think I've talked about the dietary and physical activity approaches. They have been found to be effective with helping to decrease BMI. I wanted to talk a little bit more about dietary strategies when it comes to low-carb diets. Interestingly, standard portion controlled diets are as effective as modified carbohydrate diets. And with the low carbohydrate diets in children, there's low adherence versus kids are more likely to stick with, adjusting their portion size. The other thing is really emphasizing energy density of food using a traffic light format. So red are high energy dense foods like raisin, bagel, hot dogs, and green are low energy dense like grapes or whole wheat bread, fish. So just, snacking on grapes versus raisins can really increase the density, and you actually get more in terms of number for the same amount of calories. And also reducing portion size is important. So these behavioral strategies have been effective. The most effective intervention has been like if you're able to spend 26 hours of contact time over a year. And 6-year-olds that are overweight or obesity, there's about 70% of studies that have found some effect on decreasing BMI. So this can include like a group-based intervention, nutritional and physical activity counseling, and also some component of physical activity during the intervention as opposed to when they're not with the group. Low intensity interventions are what you typically see in the primary care office. And, less than 25 hours over a 6-month period is less effective, but may be appropriate for a child with mild obesity or slight, right at the, say, 95th percentile. So this would include nutritional and physical activity counseling, and also a referral to a dietitian. What are some of the pharmacological therapy we use in treating obesity? So I have to say metformin, even though a lot of people use it, it's really not FDA approved to treat obesity. It's an anti-diabetic medication, and it really doesn't work that well. So weight reduction in both teens and children is about 1 kilogram per meter square over 48 weeks or over 6 months. And it's interesting because a lot of insurance companies will require a trial of metformin before approving other drugs that are FDA approved to treat obesity. Orlistat, I've never used it, but when I've talked to some patients who have used it, it's not pleasant. It is approved for use in kids 12 and older. It's an intestinal lipase inhibitor, so the side effects are not pleasant. Steatorrhea, fecal urgency, flatulence. So a lot of patients will stop using it just because of the side effects. Qsimi is phentermine and topiramate, recently approved to treat obesity. It's an oral medication. Phentermine reduces appetite as a non-selective serotonin and dopamine reuptake inhibitor. And topiramate has central effects on satiety. So this combination drug was shown to decrease BMI by 4.8 to 7.1% compared to an increase effect that was observed in the placebo group. Some of the side effects are listed here. Oral contraceptive or some type of pregnancy prevention is required because topiramate is a potential teratogen. So I have had no experience using this drug. Each medication individually was previously approved also for treating childhood obesity. I'm more optimistic about the GLP-1 class of drugs. These are incretins, and incretins are gut hormones that have multiple effects that contribute to weight loss. So it affects the brain centrally to increase satiety. For patients with diabetes, prediabetes, it increases your body's abilities to secrete insulin and also to decrease glucagon, so your blood glucose levels remain normal. It decreases the rate at which food leaves your stomach, so gastric emptying. So it has really very many beneficial effects. The first one that was approved for obesity in children is Saxenda, and it was approved in 2020, and it's injected daily. And in the initial study, there was a decrease in BMI from baseline by 5% SES compared to placebo. And recently, a weekly version of a GLP-1 agonist, Wegovy, which is semaglutide, was approved for children 12 and older. It's a weekly injection, and it decreased BMI by 16% compared to an increased BMI of 0.6% in the placebo group. It's contraindicated if there's a family history of medullary thyroid cancer, but side effects, nausea and vomiting. So you really have to counsel the patients about not snacking frequently because of the effect of gastric emptying, delaying it. But the real inhibition to using this therapy is cost. So a lot of Medicaid plans will not approve this if you don't show failure to metformin, which is not even indicated for treating obesity. Okay, so diet and metformin before they will approve treatment with GLP-1 agonists. And if you have commercial insurance, if your insurance does not have an indication for treating obesity, then there's no way you're going to be able to afford this unless you pay out of pocket. So there's some surgical intervention. I'm just going to go through that very quickly. So weight loss surgery in adults has been shown to reduce BMI significantly and reverse comorbidities such as type 2 diabetes, hypertriglyceridemia, decreased mortality. So we need to have some options for severe childhood obesity because of the increased risk of comorbidities, poor quality of life, and decreased lifespan. All right. So I'm really focusing on what we have found with surgical techniques, and I will focus on Roux-en-Y gastric bypass and the vertical band gastroplasty. So sleeve gastrectomy, about 80% of bariatric surgeries performed in adolescents will use this approach, where the stomach is resected to create a smaller tube. So the greater curvature of the stomach you see goes away. And so there's just less food that can fit into the small sleeve of a stomach that remains. This is less complex than a Roux-en gastric bypass, where a small stomach pouch is made by dividing the stomach and attaching it to the small intestine. So you can see it gets attached to the small intestine here. And the pouch initially holds about an ounce of food and later can be stretched to hold about 1 cup. So about 20% of surgeries have been performed in teens. And a meta-analysis have shown that there is a significant reduction in BMI with the Roux-en-Y gastric bypass, about 16.6 kilograms per meter squared, versus the sleeve gastrectomy, 14.1. And this is due to a decreased caloric intake, increased satiety, so changes in neurohormone, peptide YY, and bile acid signaling, especially in the sleeve gastrectomy, are thought to contribute to the decrease in caloric intake. All of these procedures have been shown to show improvement in comorbidities. So for studies where there was a prevalence of hypertension ranging from 22 to 100%. There was like 100% resolution after surgery. Dyslipidemia, there was a reduction from 8 to 86 to a median of 50%. And for diabetes, with a prevalence of 33%, there was 100% resolution. So in summary, obesity is escalating across all ages in the US and all ages in pediatrics. And it directly impacts growth and development of these children, increasing their risk of chronic disease, including diabetes, heart disease, liver disorders, and other problems. There are treatment guidelines for clinical care that recommend a staged approach involving diet and physical activity changes. There are newer treatment options to help children, especially adolescents with severe obesity, including new pharmacological agents and surgical options that can help to reverse comorbidities. Thank you very much for giving me this opportunity. We just have a few minutes for questions.
Thank you
Colleen,
very much. Oh, go ahead.
Colleen, that was excellent. Thanks for educating us. You mentioned about the correlation between preschool obesity and what happens later in life. Is there any data on babies and infants? Because we all like them chunky, and is that something we should be concerned about?
Yes, we should be concerned about it, especially for kids who are under 3. I had a slide, but I took it out. So I don't know, to be very honest with you, Dr. Mathieu, the data later on in adulthood as far as like older adults. But we do know that when you're less than 3, the fact that the child is obese, parental obesity plays more of a role in terms of future risks of obesity in adulthood and those very young kids versus once you get beyond 7 or 10, the fact that obesity has persisted is more of a problem.
Thank you.
Dr. Buggs-Saxton, thank you very much. That was very informative. One of the questions I have, or maybe you can guide us in terms of the delivery of changes that need to be made, especially, with some cultures favoring children to be a little bit on the heavier side than on the slender side. And especially when we're talking about adolescent girls or pre-adolescent girls as they're kind of fluctuating with weight and starting to put on weight, is there a good way to kind of present this information as a problem to the families while still not contributing to some of the concerns or what self-esteem issues that some of the girls might have with this?
So I think, body language is very important. And so I think really, I try to connect with a child, especially girls, and just tell them, you're beautiful. I like your smile, and I just want to make sure, I keep you as healthy on the inside, and outside. And so I think just getting buy-in from them, I think eye contact is very important, and just also letting them know they're not by themselves. So I share with family, I see lots of, children like you, and it's my goal to help you, and to just let them know that you need their help to keep them healthy. And also, I think being sensitive. Sometimes kids cry, and I think just stopping and just asking them, like, why are you crying? What are you worried about? And talking to them about that. And also giving them, empowering them, that they can make some changes and they can, impact the course of this disease with a lot of work. I also let parents know and the child know it's going to be a lot of work, and I'm not expecting things to reverse overnight. Set realistic goals, just first, like, let's try not to gain any more weight, and then we can talk about losing weight. So those are some of the strategies, and also getting buy-in from the family, finding out who's the person shopping. I just had a patient the other week where the grandmother was just buying lots of food. And I just said, we have to really show them what's going on. And this is a good opportunity to send them home with a growth chart, so the other family members can see, okay, this is a problem. So those are my thoughts.
Thank you. Are there any other questions for Dr. Buggs-Saxton?
I have a question. Colleen, thank you for that. I hope you'd be prepared to share your slides because they were very, very informative. One thing I don't think you mentioned, and I'd be interested in knowing, do you talk to the parents about what supplements they're also giving their children and some of those interesting things you see in the shelves of the international food stores? I often worry, what on earth are in those things, and are they giving those to children, and what the effects might be?
Sometimes parents will share that information with me. I think one other thing that they think is a healthy option is smoothies, like, oh, I give them smoothie, and you ask them, well, what do you put in it? And oftentimes they'll put more in that smoothie, especially like fruits that they would not even eat, at one setting. So I had one patient who was making smoothies with 4 apples, and other things. And I said, you wouldn't sit down and eat 4 apples. So I think to your point, Graham, it's important for parents and for children to pay attention to what's in the ingredients of whatever they're eating, be it a supplement, be it processed food. So I do try to take an opportunity to educate them about that, and really sticking to natural sources of things that have less chemicals and other ingredients that we see in processed foods. Any other questions?
Colleen, I just had a question, and it's a little vague, I know, but I recently had contact with a young adult who was selling diet aids that were, it was like a liquid supplement. And I'm sure that it had some stimulants in it. But, then I was doing some work on the research online and seeing that these have become very popular. Have you run across this in your practice, people trying to lose weight this way?
I haven't in particular, but, I try to counsel patients, even when they want to do like a low carb diet, that it's not sustainable in the long run. I mean, they want immediate effects, but a lot of those effects will go away once they stop using whatever supplement they're using. So, but I don't know any in particular that I could speak about.
Okay, thanks. And what do you think about the fad of intermittent fasting?
I think once again, it's not sustainable, especially in children, and it also, I think for adults, maybe if they want to, but I don't long term. I don't think it's something that a lot of people are able to commit to.
Thank you.
Dr. Smith, I was just going to say, Dr. Smith, when you were talking about having that conversation with adolescents, I think those motivational interviewing techniques where you can find that discrepancy between, what their current behavior is, and after you've presented all that information, trying to hear whether or not they are okay with where this is going, or how the consequences of the behavior. And then just kind of rolling with the resistance, acknowledging, it is hard, and or you might like the way that you look. You know, when you hear my concerns about where this is going, you know, what do you think about that? So kind of trying to push them closer to having some discrepancy between what they're doing now and that change.
Mhm. Thank you. And then there is a question in the chat, whether or not, what is the end point of discontinuing metformin once it's been started?
So if it's been started for weight loss, so there are a few endpoints, you know, of course, if there are side effects that you can't tolerate, you know, that's an easy one. I think if it's not giving you sustainable weight loss over 6 months, and there's no concern about worsening like insulin resistance, then I would stop it. And or if the patient can tolerate it at a lower dose, I would continue it and maybe add something to it. And it all depends on the patient. If I have a patient who is not losing a lot of weight, and I want to switch to a GLP-1 agonist, which can also be associated with GI side effects, then I may stop the metformin before starting the GLP-1 agonist.
Thank you. All right, everybody, we are over time. Again, thank you very much, Dr. Buggs-Saxton. This was excellent. The presentation was recorded. Jen Grant will send out that information if you'd like to access it at a later time. Thank you very much, everybody.